this session is not about me able to give you all individual advice. That's because all our circumstances in which we live are very different. We all have past history, current history, lots of things that goes into the making up of the decision about how we treat women with these symptoms. So what I've therefore done from the last time I did this, last time I kind of did a little bit of a talk and I left it as an open session for people to ask me questions. I did not do a PowerPoint presentation because I genuinely don't believe in PowerPoint presentations. However, I thought I'm doing this session to a team of professionals from this hospital. I need to look back at the evidence myself to make it a little bit more evidence-based. So therefore, I have put this presentation together. I'm going to go through that. Hopefully, I'm not going to bore you with too much of data. The slides where there's too much of data, we can miss that because we don't want to get bogged down by data. Because at the end of the day, what matters is what matters to us as individuals. And it's interesting to see a cohort of women who are all of a same age group here. The team here, our wellness team, yeah, have kindly put these things together because I was going to go online and bring all this up, but it's not needed because they've got it all up here for us. What I would have been very happy to see is some men in the audience because it is the men who need to, no, he's young. I'm talking about an older man. He's a young man. He's a very young man. So he may not be able to relate to what women of an older age go through. I should not use the word older, I think, but we're all in that group. But it's nice to have that knowledge because when your better half goes through this, you will at least be well informed, okay? But it would have been nice to see some men, but men never come to these. And they just do not get what women go through. They genuinely do not get what women go through. So the most important thing, I've got Indian women there. That's because I'm an Indian by birth. But it's the same thing for all of us. These days, women spend 1/3 of their lifespan in the postmenopausal phase. And it has a great bearing on the quality of the life we live, especially when lifespan has increased. Majority of us live up to the age of 80 plus these days. So we're from the age of 45, 50, up to 80, that's 30 years of your lifespan going through these symptoms. It's quite a lot, okay? And the symptoms of menopause, if you go into a journal, medical journal or a textbook, you will find this. But I can tell you pretty much it stops from the top of your head right up to the toe, and you can talk about everything. From loss of hair, to hot flushes, to night sweats, to saggy skin, to not looking as good as you would look before, to unexpected flushes that come up your cheeks when you don't want them to look that way. You can go through the entire system from top to toe and you will find every symptom that goes through our body. Needless to say, your sexual life pretty much becomes non-existent, okay? I'm a gynecologist. My very first title, I put my big qualification in it, not to show off, but to say I've got the ability to speak about this. And I don't think I will feel too shy talking about sex or, because that's a part of our life. I think it's, there's a lot of taboo talking about it, but it's just a part of life, okay? And even to this day, when women come at the age of 60 plus 70 and tell me about, doctor, I'm not able to have sex, what do you want me to do? Literally my jaw drops and I'm thinking, oh my God, I need to change the way I live my life. Because there's still women out there who are interested in sex. But that's not the focus of our bone loss and muscle weakness and inability to wake up in the morning, aches, pains, pretty much everything. Everything goes through the menopausal age group. And if you look at the osteoporosis risk factors, you can see it's like an acronym which says access. You can talk about alcohol, corticosteroid use, low calcium, low estrogen features in there, which is what we're talking about, smoking and sedentary lifestyle. So that's a big risk factor. So what I therefore decided to do is, in this presentation, I picked up the most important things that are the symptoms that we are worried about with relates to HRT, and then I will quickly tell you how we choose about what HRT to go by. So when you go to see your GP or get referred to us to discuss the HRT, you have a rough idea of what is it you want to ask, if that makes sense. And HRT is not, I don't have shares in any of the companies, I don't get any cut. And this talk is not about promoting HRT, it's about you identifying lifestyle changes in addition to HRT to decide if that's going to help you all with your symptoms, manage your symptoms. So the first one I'm going to focus on is osteoporosis, okay? We don't know much about it, we don't talk about it because it is silent. Bone loss is silent. And typically, if you go to the orthopedic ward, I don't know if there are any orthopedic nurses or anybody from the orthopedic team, majority you will find the women there lying with broken hips and stuff like that. And they're mainly of the spine, the Colles fracture, I don't know if any of you all know, when you fall on an outstretched hand, and of the hip. And we know that 20% of the women will die within 1 year of fracture of the big, I'm talking about hips and stuff like that, and never regain their functional independence. I'm sure we've all gone through this. You say, quilt off, quilt on, quilt off, quilt on, all through the night, to the extent it interferes with your work the next day. You can't sleep. Because you can't sleep, you're coming into work really tired, and then you get angry at your colleagues. Not because you want to get angry at them, there are circumstances that make you angry as well, but it adds to the irritation, if I can say so. Fatigue, loss of concentration, so sometimes we do mistakes that we don't want to do. We all come to work wanting to give it the best, but there are circumstances beyond our control that make us do things wrong. Depression, family life, and I've also already alluded to sexual function. I thought this was very important, the hot flushes thing. You see, it is to do with where you come from as to how much you experience that symptom. So pretty much 3/4 of us, when we talk about hot flushes, that's real. It's not a made-up thing, okay? And that's statistics to support that as well. And the duration of hot flushes. If I were to go around asking you all, how long does your hot flush, how long have you had it for? Some say, I'm 10 years down the menopause and I still get hot flushes. And that's the data to support that. You see, some women cannot seem to shift that hot flush. It seems to come all through their life, while some have a fantastic menopause where they don't get hot flushes at all, who come in that 20%, who don't get hot flushes, but majority of us will fall somewhere in that percentage rate. I thought this was important statistics for all of us to understand because we are not alone in this. In 2020, which is next year, not long, remember, 1 billion individuals all over the world will be over the age of 60. And there is some data here that our team have kindly put up together, and it said here as soon as I walked in, 13 million women in the UK are going through or have had reach the age of menopause. In the NHS, close to 500,000 women. 500,000. And I'm sure there are lots of those who want to be at this talk today, but cannot be here because they're providing clinical care or they're doing their duties. Same thing. And if you look at the picture of UK there, and in the next slide, proportion of people in 2050, you're going to have more than 30. Okay? So this is a problem that's not going to go. And then we look at the HRT use. This is because of a big WHI study that came up which put the evidence down, and then it started going up. This is where it went down, and now it's again going up a little bit because of some supportive studies that have come up. This was the study that I spoke about. The primary aim of that study was to see if women who had commenced on HRT, were there benefits, were there disadvantages. It was a huge study, but the difference was that it was started in an older woman, not in a woman who is after the age of 50, in whom we would majority of the times prescribe HRT in UK. And that was the headlines of the WHI study. We're not going to go into that. But they called it as a wasted decade of the HRT scare. And this is quick data. The 3 biggest scares about HRT are breast cancer, stroke, coronary artery disease. Okay? And that kind of explains when you... I'm going to stop at this slide for a second because though the slides are coming up later, the basic principle of HRT is if a person has got an intact womb, i.e. they have not had a hysterectomy, then the woman needs both estrogen and progesterone if they want to decide to go on HRT. Okay, you cannot give them unopposed estrogen because that will increase the risk of endometrial cancer, that's cancer of the lining of the womb. Okay, so we have to give them both estrogen and progesterone. If we have had a hysterectomy, then we can give them estrogen alone. Okay. Now, once you know into which group you fall, which I have kind of alluded to at the back, I bet the one thing that I want to find will never come up there. So this is what I was trying to allude to when I go through the list. We don't want to go into the details of it, but pretty much you're starting off with, has this woman had a hysterectomy or does she have a Mirena coil in situ? A Mirena coil is a hormone-impregnated coil, which we use quite regularly for contraception or for women of beyond the age of 40, 45 when they've got period problems. One of the common things, you go to your GP or a gynecologist, they'll say, do you want a Mirena coil in? Okay. So if they've got a Mirena coil in, that has got the progesterone hormone in it, so you just need to give them the estrogen. Are you following that conversation? Again, once you decide if you want to give them estrogen or progesterone, estrogen and progesterone together, then you pretty much follow this flow chart. We're not going to go into the details of it, but the other important thing to understand is if we decide to give a woman estrogen and progesterone together, again, you can give it to them in the form of tablets, patches, gels, rings, lots of things available in the market. At the minute, all the pharmaceutical companies are suffering a tiny bit because some of our stuff comes from Europe. And we are really having problems within the formulary to procure all of them. And the challenges that we are facing, I'm not going to go into the politics of Brexit, that's not my role today, but that is a real challenge we are having with medicines procurement. And so what's happening is because there is a challenge, if one of you all are on a form of HRT, because we're not getting that form, we have to change them onto a different form of HRT. And when that switch happens, women have unscheduled bleeding. They've not had bleeding all these years, and suddenly they are bleeding, and then you're embarking on a whole pathway of trying to find out why they're bleeding. They need an extra investigation, a scan, or a hysteroscopy. It's only because of change of medication, but you still cannot give the woman the guarantee that everything is okay. Right? The other thing to remember is when we decide to give women both estrogen and progesterone, that's if you've got an intact womb and you do not have the Mirena coil. If you are still having your periods, initially you need almost like a pill. It's called as a sequential form of HRT. So you get estrogen first and then we add progesterone to the later half of your cycle. But if you're starting HRT after your periods have stopped, then you need a combined form of HRT where both estrogen or progesterone are there throughout the cycle. Does that make sense? In the first category, we're adding progesterone for the later half, so you every month, it's almost like being on the pill, where you will get a period every month. It just regularizes your periods as well. Whereas if you're on the combined HRT, you take estrogen and progesterone throughout your cycle so you don't get a period. Okay? Remember, HRT is not contraception. I know your sex drive goes down when you've gone through the menopause, but when you go on the HRT, it's possible that your sex drive goes up a tiny bit, and then you don't want the unplanned pregnancy. That'll be then you would come back and tell me, oh my God, your lecture, we've got ourselves pregnant. No. Remember, it's not contraception. You have to use other methods of protection. Okay? Yeah, so we were talking about this study. What they found in that study was if the women had estrogen and progesterone together, which we spoke about earlier, they were the headline said 29% more heart attacks. It seems to be a big number, correct? 29%. But then if you see that, it's 7 per 10,000. Are you still with me? So in the overall scheme of things, the fact that...
Is that 29% more than not taking anything?
That's correct. 29% more than not taking anything, but there is a slide. Basically, estrogen itself does protect. As long as we get the periods, women will not get, majority of the women, I cannot say they will not, majority of the women will not get a heart attack. That's because estrogen is protective to your heart. The minute we've gone through the menopause, our risk of getting a heart attack is exactly similar to a man. So you will never see a woman in the cardiac unit below the age of menopause. It's usually after the age of menopause because the protective influence of estrogen is lost. Okay? So we're all at a certain rate of getting a heart attack. Obviously, that rate goes higher if you are bigger, if you have no exercise, you smoke, you drink. All those factors, when they start creeping in, your incidence starts going up. But more importantly, that's what the study was trying to state, that if you take the estrogen and the progesterone, your risk goes up 29% more than the base risk. Does that make sense? So this is just a graphic representation of, I'm just going to use the mouse to say, if you see this here, this is mortality from heart disease, but this is US women, okay? And if you see that here, that is when it's steeply going up. And that's to do with the menopause and your lack of estrogen. And that goes up higher when you're on the HRT. So if there are any cardiac nurses, it's for them to realize that having a heart disease is not a contraindication to a HRT, but more importantly, if the woman is struggling with other symptoms, you need to have the risk-based discussion with the woman to say, what is it that she wants to do about going on the estrogen or the progesterone? And then there is a new study in 2016 that came up to say estrogen therapy might actually be cardioprotective because we have had the protection till we go up to the stage of menopause. And that's why I was talking to earlier on before all of you all settle down, that if you all are wanting to make the decision about starting HRT, start it earlier rather than later. Okay? Don't wait up to the age of 60, 65 and then start. The benefits may not be as much. It's better to consider, if at all you want to consider starting HRT. And as I said, it may be harmful if started after 10 years of the menopause. The other worry about HRT itself is venous thromboembolism. That's if you get clots in your legs or lungs. The reason it does that is because the HRT affects the lining of your blood vessels. Not going into the details of pharmacology, but basically if you stick a patch or if you use a gel as a HRT, it does not pass through your liver. So it's a little bit more safer than taking tablets because tablets have to go through your liver for metabolism. And therefore, it might potentially increase your risk a little bit more. Yeah? I'm happy to share these slides. These are not, it's just latest medicine. So that's the reason we will not screen universally for VTE. Moving to the breast cancer, there are lots of leaflets that the Cancer Aware team have put on your thing. It is about, the challenge with breast cancer is, we are all at a certain age where breast cancer is very common after the age of 50. So it's really, really important that women engage in screening. That's the most important thing, okay? And I've got another slide later on, I think, that one, okay? And this is displayed here as well. Once we finish the talk, you can go around looking at it. It's only when you look at it visually that you understand the risk of. So 23 cases of breast cancer are diagnosed in UK general population. So for additional 4 cases, those darkened women there, if they are on the combined HRT, right? For fewer cases, if you've had a hysterectomy and you're just on the estrogen. An additional 4 cases if you've been on the pill. Okay, if you look at it, so you understand that people make a lot more exaggeration about the risks of HRT when compared to the other risks you have. So if we all drink 2 or more units of alcohol per day, your risk is equivalent or a little bit more when compared to going on the HRT, right? So 3 more additional cases if you're current smokers. This is staggering when you look at that, a BMI more than 30, what your risk factor is. 24 greater cases of breast cancer if your BMI is more than 30. And 7 fewer cases if you take a moderate amount of exercise, right? So if we were to put all these things together, and a BMI of more than 30, I'm not talking about BMI 45, 60 or any of that. I'm just talking about a BMI of more than 30. With our busy lifestyles, if we fail to do exercise, alcohol, smoking, and HRTs. So what happens is you've already accumulated all these risks. We've got a background risk of getting breast cancer, and you then go and take HRT. The HRT gets blamed for the cancer. Does that make sense? So it's really, really important that your lifestyle interventions are paramount, and that will come through all through my talk, be it for breast cancer, be it for your vasomotor symptoms, be it for muscle and bone loss that we all experience after the age of 50. It's fascinating. There's something called as sarcopenia. That's a new term, I think, but basically it's muscle mass, loss of muscle mass. Women, it's not 100% certain if women experience that, but all your aches and pains could be secondary to that loss of muscle mass that women go through after the age of menopause. So the only way you can protect yourself from preventing that muscle loss is by taking regular exercise. Okay? It could be just walking. It doesn't have to be high impact exercises. What do they call? Aerobics in the gym or high impact training for 45. Whatever, it doesn't have to be that. It could be just gentle exercise like yoga or Pilates or walking with your dog or anything, but it's important that you do exercise at least 3 or 4 times a week. I cannot stress that more. The other important thing that I thought I'll put a slide on this is because when women, this is not pitched at you all, but it's just for you all to be aware. When you go to see your GP, I would have loved to do this talk to the GPs as well. One of the common things they come back and tell me is, my GP has done blood tests and they tell me either that I'm going through the change or I'm not going through the change. A blood test does not have to be done to diagnose menopause. If you go to them at the age of, say, 48 and tell them I've got hot flushes, night sweats, I can't sleep, they can pretty much say you're going through the perimenopause. It's perimenopause, it's all in the name, it really doesn't matter. Menopause means you have stopped periods for, meno means blood pretty much, okay? So if you stop bleeding for a whole year, and then after that you have all these symptoms, you are menopausal. But if you're around the age of 48, you still get your periods, and you have all these symptoms, you are perimenopausal. It's not long before your periods are going to stop. To add on to this, women commonly have period problems at this age as well. So you can see it's quite a lot that comes to hit a woman. This is something I thought, I didn't know if I'll have a lot of these women today, but I just thought I'll put in a slide. If women under the premature menopause is women under the age of 40, so 41, 42 as well, technically they are entering the perimenopausal age, but you could class them as going through the premature menopause. It's an incidence of 1 in 100. If they do not have risk factors, i.e. they're not obese, they don't smoke, then you can pretty much put them on the combined oral contraceptive pill, because that will be two birds with one stone, i.e. your contraception and your menopausal symptoms sorted at the same time, provided you do not have any other contraindications for the combined oral contraceptive pill. Otherwise, they can go on HRT as well. And HRT is beneficial in this group. This is the most important thing that all of us want to hear about. That's your vasomotor symptoms. Vasomotor symptoms are your hot flushes, your night sweats, your lack of sleep secondary to that. Those are called as vasomotor symptoms. When you go to your GP, because of the lack of, I'm not sure if lack of awareness is the right word, but people are very scared of prescribing HRT. So what then happens is they start them on fluoxetine or paroxetine or clonidine. They should not be your first-line management strategies for management of these symptoms. They work, but they do not work as effectively. Things that you can do to help yourself not having these vasomotor symptoms are wine, caffeine. You see, caffeine is not good for your menopausal symptoms. Small lifestyle changes that you can do to help yourself are the most important thing that you can do to help you with your symptomatology. Probably simple tweaks like, when you have these little, Katie was just telling me about menopause cafes in Sheffield. Apparently, they've got these menopausal cafes. Basically, I'm sure there'll be women sitting together and say, I've turned the heating down to help me with my symptoms, or I can bake menopause muffins, which there are some recipes here, or I take soya and quinoa in my diet, or lots of little things that you can do to help yourself from preventing most importantly, stop wine, okay? I just thought I'll put in a couple of slides about complementary therapies. I've tried to pitch my talk pretty much on what I get asked when women come to see me. Many of us buy St. John's wort or evening primrose from Boots. It has shown to be efficient, but the problem is we are not sure about the dosage. And does it have any other serious interaction with other drugs is what we cannot say, but there is some effect to support it. Most important, relaxation. So your whatever class you're going to come, meditation, yoga, anything that helps you relax does improve the quality of your life. Acupuncture and CBT have shown to be very effective. This is the urogenital atrophy is a very medical term, but basically it's about your inability to have sex, or it is the vaginal dryness, or it is about urinary problems that women might have. One of the commonest things against that happen is because the urethra, epithelium of the urethra also is supported by estrogen. So when women lose the estrogen, there is a tiny bit of stinging when they pass urine. And they go to a GP. GPs, I don't blame the GPs. They literally get 5 minutes or 7 minutes with each consultation. They dip their urine. It's not a midstream urine. You're just collecting a sample of urine. They dip it. They find a bit of leukocytes. They say you've got cystitis, and you get a course of antibiotics. It is not because you've got an infection. Not always. Sometimes we do get infections, but it is not the infection. It's the lack of support to the uroepithelium that makes you get those symptoms of burn. So constantly women get treated for cystitis or bladder infections with antibiotics. What happens secondary to that? They get thrush and burning in the vagina secondary to the thrush. So it is not repeated infections. It is because of lack of epithelium in the uroepithelium. So you can give women vaginal estrogen. And in the past, there was a lot of worry about giving vaginal estrogen only for short time. But now the British Menopause Society says you can give topical estrogen. Topical is just into the vagina as long as it's needed. Recently, there's been a change in the license for vaginal estrogen as well. In the past, as I said, it used to be 3 to 6 months, but now you can give it indefinite usage. And the other common question I get asked as well, these are just the different preparations of how you can get vaginal estrogen. Again, I think there is a problem with procurement with one of these. I don't know the top of my head which one that is. So I've kind of mentioned this already. But whenever you have unscheduled bleeding on HRT, you will have to get yourself checked out. I've already alluded to this. So for low mood is real. It is not made up, okay? There are lots of other stresses that happen in a woman's life around this age. It could be marital problems, it could be work-related problems, it could be a manager who's a young, should I use the word lad? A younger male who does not understand what you're going through, who is constantly putting pressure on you to deliver things. It could be different things that put you through this low mood, because then you almost start feeling worthless. Oh my God, I've done this job all these years. What's happened to me? Why am I not able to deliver this? And there is not clear evidence. That's a very scientific name, the SSRIs. It's the fluoxetine and the paroxetine I'm talking about that women get mentioned. We've already spoken about clots. Ovarian cancer, there is some study that the long-term use of estrogen only or combined may be associated with a small risk of ovarian cancer. But again, it will return to baseline if you stop treatment. We have done osteoporosis already. I just thought I'll mention a little bit. Sarcopenia is the muscle loss that I already spoke to you about. Dementia, this is a real problem to all of us. Somebody asked me something, oh, did you do the same talk last year? I genuinely cannot remember what happened in my life 3 days ago. I have to literally sit and think. It'll come. It is not that it won't come, but you have that time span before you get a person's name, or you know them very well, but suddenly it won't come out. It just takes that little longer for you to get that processed in your brain. And the one thing I used to take pride is my memory, and it's shocking when you cannot remember things. It's really sad, but don't let that go downhill. It's really important that you keep your cognitive function stimulated at all times. Reading, puzzles, whatever, they do help you. Chanting, difficult, whatever you want to do. But keep that going, otherwise that will drop down very quickly. We have already done this. Which HRT, I've already done that as well. I just thought I'll mention a little bit about testosterone because of libido, lack of libido. There is a lot of decline in the testosterone levels in women. On Tuesday, there was a talk here in the lecture theatre about testosterone in men and women. Despite my busy clinic, I came running to listen if he would tell us something about testosterone in women. But sadly, the lecture did not cover the use of testosterone in women. We do prescribe testosterone gel in very few situations, but the women have to understand that prescription of testosterone gel for lack of libido is out of license. The doctor has to prescribe it. We have already alluded to alternatives to HRT. There are some really good food products that people need to be aware of to help yourself with your symptoms. And the team have kindly put some thing together. But Japanese women, if you remember that menopausal symptoms, do not get hot flushes and night sweats because of the soya protein that they consume. Soya has got natural estrogen in it. So if you'll like soya protein, please try and make some recipes out of that. And I've also given you a list of other alternatives one might want to consider to help yourself with helping you with your symptoms. None of them is particularly difficult to procure, I guess. I already alluded to contraception. Remember, you all are not protected. In anybody, if you all remember, as I said earlier on, I cannot give individual advice to each of you because all our circumstances are so different. If you all want to, please get your GP to refer us. But as I said, majority of the GPs are good enough in prescribing this. Most important, I think that's pretty much my last slide. Use this. If you want to walk out of this door thinking, I've just gone around learning this one thing, it could be some recipe, or it could be, I will do more of this, or I will do less of this, whichever. Okay. Any unscheduled vaginal bleeding, please make sure You comply with cervical screening and make sure that gets checked out. It's got lots of foods that are anti-carcinogenic, anti-aging, and lots of these like simple things like turmeric, and it's used in everyday cooking. And now what's fascinating is Holland and Barrett and Costco, everybody sells turmeric capsules. And what's fascinating is India, which should continue to use what it has now stopped using it, and they're buying capsules. And I'm thinking, what's wrong with this world? Seriously, you just go back to what you were doing before. You don't have to go and buy capsules. It's really fascinating. I think it's the mindset of the population that needs to change.